Thank you, everybody, for joining us today, this afternoon, this evening, this morning, depending on the time zone. It's my pleasure to welcome Professor Doug Evans. He's a professor in prevention and community health and global health at the same time in Milken Institute of School of Public Health at the George Washington University. Dr. Evans has published more than 250 peer-reviewed journal articles, books, and book chapters. His work focuses on the translation of communication into health promotion and disease prevention in the United States and low and middle-income countries. He studies digital health technologies, including artificial intelligence, mobile phones, social media, and other applications to changing health behavior and increasing demand of health products and services. He applies these methodologies to reduce health disparities, and today he's going to talk about AI, artificial intelligence, and digital media for social and behavior change. Without much further ado, I'll let the floor to Professor Evans.
Thank you very much, Marco. Appreciate it. Very pleased to be here with you today. I'm going to give you kind of a broad overview of my research in this area on AI and digital media for social and behavioral change. I'm going to talk about kind of my theoretical perspective, sort of background on this work, some methods that I've been using over the last several years in particular, and then I'll dive into some case studies that hopefully will illustrate the work that I've been doing and hope to be doing in this area in the future. Just want to start by acknowledging some grant support that I've had for some of the projects that I'll mention here today, both from the National Institutes of Health in the US and also the Gates Foundation. I'll be talking about some projects that were funded by those sponsors. And if I weren't here today doing this right now, I'd hopefully like to be traveling or out cycling, two things I like to do very much. So I always like to put a plug in for that. So just kind of an overview of what I'm going to talk to you about today. I'm going to describe the growing field of AI, artificial intelligence, and digital media for social and behavioral change. And those of you in the UK will pardon my Americanized spelling of various words, but no you in there in behavioral. I'm going to talk about the relevance of these fields to public health, and in particular to health behavior change. As I mentioned, I'm going to give you some use cases or case studies. I'll talk about various kinds of messaging strategies using digital media, and then I'll draw some conclusions and talk about future research opportunities and challenges. So I have a perspective in my work on the use of strategic communications and marketing strategies. Marco alluded to that in the introduction for behavior change. These are sort of foundational strategies for changing behavior. And a big part of that for me is the idea of branding, using branding for behavior change. So, we think of brands in the context of commercial products and services. Companies are branded, but really what brands ultimately boil down to are values, human and social functional values with which audiences identify. And so brand marketing strategies have been used for social and behavioral change increasingly over the years. And in research that I did about 10 years, a little over 10 years ago, we showed in a systematic review that branded strategic communication is on the whole more effective than what I defined as unbranded in population health campaigns. Basically, there are bigger effect sizes. These campaigns are more effective when they are strategically, intentionally branded. And digital media and AI are very powerful tools to build brands. We have increasing evidence base in this even more specific area. And this approach has been especially successful in areas like tobacco control. A good example of this is the widely acclaimed Truth campaign in the United States, which is an anti-nicotine and tobacco use initiative, a series of campaigns that have increasingly been digital in recent years. So this is kind of a foundational theoretical principle and approach that I use in my work. And just some examples of what I'm talking about here. This is like kind of an early case study. I'll just mention in passing in some ways, a program that we developed in the Washington, D.C. area called Adelante, It was designed for Hispanic and immigrant youth in the DC area, in a particular region around DC. And one thing that we did was we developed this very identifiable brand. You can see a logo there, the Adelante logo, which basically represents kind of making good life choices, that this program provides a source of strength, resilience, helps you through a tough life, tough upbringing for Hispanic and Latino immigrant youth. And another thing we did was we developed this educational entertainment series, or edutainment series, called Victor and Erica. It was actually enacted by youth who were from the community, and it showed them basically living their lives, going through various trials and tribulations, and hopefully succeeding in the end with the help of the Adelante program. Kind of a melodrama, soap opera, if you will, that was very popular on YouTube. And so we developed, this is 10 years ago or so, in kind of earlier days of digital media interventions. And as part of this, we developed an integrated digital and community-based social marketing campaign. And the goal of it was to, again, this idea of branding, to build a positive identification with a population health program in the specific area we're working in the DC area. One thing, this young lady on the right, you can see, I talked about values. Well, one value is Adelante's strength. It's a source of strength for you. And, the campaign was delivered both in English and in Spanish. That was sort of part of our branding, like the identity of the program is it's multicultural and integrated into the community, but also digital intervention. So some of the values represented there. So what is this field that I'm talking about today of digital media for social and behavioral change? So let me try to define that a little bit. I would place it within the broader field of digital health interventions, or DHIs. If you search on that literature, you'll find that there's a large and growing literature on digital health interventions writ large. That includes a lot of things that are not the specific focus of what I'm going to talk about today. So like medical devices, for example, would fall into that field. Even though I am using devices in some of my research, like apps, for example, other features of mobile phones, they're not medical devices per se. What I'm really talking about are campaigns, interventions, programs aimed at changing specific behavior or behaviors in a population using one or more digital platforms as the delivery channel. And this includes, and you'll see some examples of this in a few minutes, research aimed at assessing the effectiveness of such programs. But how effective is this methodology, and under what conditions does it work? We published a paper a few years ago, kind of a theory methods paper that's cited here at the bottom, that goes into more depth in defining this field, digital media for behavior change. We, as a part of that, that aspect of my research agenda, a few years ago, we founded an entity called the Bright Institute at GW, which is focused on behavioral research, insights, and digital health technologies. And it's a cross-university institute. There are 6 colleges and schools within GW, my institution, that are part of this, and a large number of faculty. It's basically a platform for collaboration, for innovation, to help build multidisciplinary research related to AI and digital media for behavior change. And in particular, the Institute is part of a larger initiative at GW that's focused on the use of AI for social good, called the Trustworthy AI Initiative. It's one center or institute of many that are part of this larger initiative at the university. So maybe a little bit more about principles and theoretical foundations of this field before I move on to some specifics. One approach that I've used, or kind of guiding principle, is that the scale of digital media, there are billions of users, for example, of the Meta platforms, Facebook and Instagram, just as one example. This huge scale, everybody has a mobile device and so forth, may create a sense of widespread support for and adoption of specific behaviors. There's the sense that there's a powerful social support and social influence. And in particular, social media campaigns may promote a norm, like the idea that everybody's in the digital world, everybody is in favor of using digital technologies for a variety of things. Hopefully, not just entertainment and debating politics and so forth, but also to promote specific healthy behaviors, things like vaccination, nutrition, physical activity, avoiding nicotine products. And so that's been kind of a guiding principle of my work, is that we can change social norms, and that's a mechanism, a theoretical mechanism that can be reinforced to promote positive social influence. And this can be done through digital channels, but also in combination with more traditional analog, if you will, community-based channels in particular. So those are some just basic theoretical foundations that I've used in my work. And now I'm going to talk a little bit about methods, and in particular about methods related to the use of artificial intelligence for behavior change. So let's sort of dig into this a little bit. So I've given some thought over the last several years to how we can leverage AI for social good. And one area of work that's a bit more advanced, frankly, than I think we are at the moment in public health is the use of AI in marketing, and so commercial marketing in particular. And so, there's been a fair amount of work leveraging tools like large language models to produce and interpret consumer insights, optimize content, personalize the consumer journey. These are some basic features of AI that make it incredibly powerful. Like, I can basically guide you through a consumer journey of becoming aware of a product or service, recognizing the benefits of it, and AI can guide you through that journey. And organizations like the McKinsey Global Institute on the right here, this is just some early work they did where they identified a number of different domains with use cases where people, researchers and practitioners, had harnessed AI for various purposes like infrastructure development, security and justice, crisis response, economic empowerment, and different areas. These are some social good promotion areas that McKinsey identified a few years ago. And so we can use these same techniques that are being used to sell products and services. They can be applied to promoting pro-social behaviors. And a couple of years ago, working with Marco Bartis and others, we did an analysis of how AI can be used for behavior change. And as part of that work, and the publication that's listed at the bottom of the slide here, we identified 6 key benefits to applying AI as part of behavior change programs: personalized and tailored support, increased scale and reach, and you can see other areas listed below here like trend spotting and rapid response. So just as an example, generative AI, so like ChatGPT and the other platforms that are out there, can address issues related to competition with unhealthy behaviors by looking at large data sets, examining user patterns, what are people doing that involves engaging in unhealthy behaviors, and developing exchange offers that are more beneficial than those offered by the competition, which might itself be just engaging in an unhealthy behavior, not necessarily like a company or competition in the traditional marketing sense. Thinking about this from the social marketing perspective. So as part of my work using these principles, one thing I have done a lot of research on is the idea of digital segmentation. This is another kind of method. And in particular, one thing we can do is use the large amounts of data that have been collected through social media. So anybody who has a social media account has, just by default, provided a tremendous amount of information, and much of that is publicly available. If you have a profile on Instagram, for example, if you've done online activities using your social media account or in connection with other online activities, there's data out there about you. Obviously, we all have had the experience of maybe we go shopping for a airfare from London to Berlin or something, or from Washington D.C. to London, and maybe we don't buy the airfare right away. Well, probably the next ad we're going to see when we go to the next website or next screen that we're going to go to is advertising for that same product or service, like advertising for that flight or maybe for some flight in general. That is basically remarketing technology. And so remarketing, or what's also retargeting technology, can be used basically to identify people based on who they are online and what they do online. And so this technology is used all the time to market products and services to people, and AI allows us to have very precise targeting and segmentation. And in particular, we can use this for things like recruiting people into studies. So just the same way that, an airline is marketing flights to people based on their online activity, we can recruit people into studies, into interventions using that same technology. So intervention studies, and I'll show you some very specific examples of this in a second, can use retargeting to direct content and dosage even. So like how much of the content, the pro-health or pro-social and health behavior change content to participants. And we can do this in randomized controlled trials. We can create very naturalistic online social media-based randomized controlled trials and quasi-experiments. There's a open source software that I've been using. There are other ways of doing this. It's called Virtual Lab that I have used for several years now to do studies like this. And I'll show you some examples in a second. So just a little bit more about this idea of retargeting or remarketing, just to bring it home a bit more. Marketers can essentially create custom audiences. And what I mean by that is, a specific demographic group and maybe other things about people's behavior. So I'm going to show you an example in a second where the demographic is young adults, 18 to 24 years of age, living in the United States. So age, where they live, and another factor in this study was whether or not they use e-cigarettes, electronic cigarettes, whether they vape or not, recently or ever. And so we combine that kind of information to direct content to users in a trial, a behavioral intervention using this same retargeting or remarketing technology. The same thing that if you were searching online for, let's say, data analytics degrees, the next ad you might see would be this advertisement. It's a little blurry there. I'm sorry about that. Picture could be a little better. But this ad for a data analytics degree, because the internet thinks you're interested in this, right? Well, we can do the exact same thing to direct content to people that's pro-social, pro-health. So I'm going to illustrate this in more detail, these methods and principles that I've been talking about in a series of case studies. So the first one, and you'll note that I've underlined the word scale and reach. That's one of the 6 principles that I mentioned earlier. So I'm presenting these case studies to you to illustrate some of these principles of how we can use AI and digital media in online interventions, online research studies for pro-social and health purposes. So this one's in particular about scale and reach. This is an anti-vaping randomized controlled trial. This is actually a registered clinical trial in the US NIH sponsored clinicaltrials.gov system. And this is a study that's still ongoing. It's been going for a few years now, where we've used this remarketing technology to identify social media users aged 18 to 24 living in the US, as I mentioned, and we've stratified them by vaping status, whether they've ever vaped or not vaped. And we, in an initial study, we ran a randomized trial where we followed people for 2 months. We were able to very rapidly, using this virtual lab technology, recruit over 1,800 participants, and then we randomized them to get different levels of exposure. So a control group, and then a little bit of exposure, more, and a high level of exposure. So it's essentially a dose response experiment conducted completely online on social media. And then what we're looking at through surveys is to examine the effect of higher levels of exposure on changes in vaping outcomes over a 60-day period of time. So basically the hypothesis is that there's a dose response effect. More exposure will produce more of an effect. And this is just an illustration of our study design. It is in fact a randomized trial. It's one of a series of studies that we've done under this grant. One just quick thing to notice is that we were very successful in identifying exactly the people we wanted. We screened 1,700 and some participants, and only 104 of them were not eligible. So our data on like who was eligible based on the remarketing, retargeting data that's available on social media was really accurate. very accurate. And so we were able to very rapidly get our sample size. This was all based on power analysis, get our sample size and then move on with the study. So the technology works very well. These are just some examples of recruitment ads. We were, again, using this concept of digital segmentation to target advertising to US young adults who fit certain other criteria. And then they interacted with an AI chatbot during a recruitment process. So basically, a post would come up in their feed, they click on the post, and then they're interacting with a chatbot that's screening them into the study. And these are just a couple of recruitment ads that we used. And we experimented a bit with like static kind of generic recruitment ads, the lady in the middle of the screen with the Amazon gift card, and then a slightly more interactive example here on the right. And maybe not surprisingly, we found some of the more interactive recruitment ads were more effective. But this intervention is completely delivered on social media. We never actually met or interacted in person with any of these participants. It's all done virtually. This is just a little more illustration of the content. So some of our content was pulled from the Truth Initiative, the Truth Campaign that I mentioned earlier. And this is some content that was not currently in their campaign live, that was running live at the time of our study. It had been used in the past. And this is from a campaign that was called Tested on Humans. So it's kind of a black humor, I guess you could say, approach to pointing out the harms, the potential harms of vaping. And this is one of 4 posts or ads that we used in the study. This is an excerpt from a TV program in the US where the CEO of Juul was on, basically admitting that he has no idea what the long-term negative health effects of using Juul products are, and even Juul doesn't know this. So it's this concept that the vaping industry is basically testing their products on you, right, as an anti-vaping message. So it's a messaging strategy using this approach. Here's another example. This is, again, a kind of edutainment, you might say, approach. This is another ad that was based on Truth Initiative content. I can get this to run here. Hang on.
I feel like you don't want me to be happy. You only ever wanted my money. You're just like your mother.
So the message being that they're, contrary to what some people believe, that, using nicotine products kind of relaxes you. It actually increases depression and anxiety symptoms. And again, using like a humorous approach to bring this message home. So those are obviously branded ads, right? The Truth Initiative is a very well-branded, well-recognized brand, especially among young adults. And we were concerned about that for various reasons that I'll mention in a second. But just quickly, this is a result of that initial study that I've been describing here for the last couple of minutes. And we found in this study, this randomized trial, completely done on social media, that there were reduced vape intentions. So 30 days, how likely are you to vape in the next 30 days? Those were reduced at follow-up among current users compared to control. So basically, people who were currently vaping were less likely to say that they would continue vaping given their exposure to the intervention. And also a mediating variable that we call anti-vape industry beliefs. So basically this idea that the vaping industry is kind of manipulating you, using you to test their products. I mentioned the Tested on Humans campaign a second ago. And basically we found that those beliefs were more positive among current users compared to control. And basically we also found that there was a dose response effect. The more of this content that you were exposed to, the more likely these outcomes were to be brought about. And you can see the publication here. And on the right-hand side, this is an example of some content that we developed. And again, it was focused on this anxiety or depression theme. And this young man shows up in a number of different posts that we created. These are unbranded posts, and there was a reason why we did that. We have moved on to a larger RCT conducted over a longer period of time, which we're just wrapping up now. And the focus of this study is to actually see whether our content can reduce actual vaping behavior over an extended period of time. We've randomized participants to the control and 3 levels of exposure. We learned some lessons in our earlier study that I was talking about a minute ago, that basically at the high end of our exposure levels, we had 4 levels of exposure in the earlier study, basically the results kind of compressed. So we reached a point where more dosage no longer produced a greater effect. So we had 3 levels of exposure, kind of building on what we learned earlier. We had a baseline sample, 2 follow-ups, and we ran multiple campaigns during this time to keep the content fresh and alive. We were able, again, to recruit a very large sample, over 8,300 participants, and they were stratified by people who had ever used e-cigarettes versus not used them. And we're just finishing the final data collection for this, so I don't have any exciting results to report yet, but that's coming soon in a publication near you. And this is just a little bit about the baseline sample. We were successful basically in recruiting who we wanted to recruit. They were average 21 years old, pretty good distribution of racial, ethnic background given the US population, about 50% of each biological sex. We also interestingly found a lot of what's called polyuse. So basically about 48% of our people who were vapors also used another tobacco product. And a significant number of them were also using these oral nicotine pouches or products, which are essentially like something you put in your mouth and absorb large amount of nicotine in a relatively short period of time. It's become a big phenomenon, at least in the US. We also found that vapors were more likely to be aware of our anti-vaping content, which is consistent with the literature, a kind of selective attention bias. And we also had scales for a number of other things like depression, social norms, and other covariates that we'll be using in our analysis. So coming attractions, results of this larger trial. And we do have a couple of early papers that are out, one that's on the design baseline evaluation of this trial. So I mentioned this idea of we used this truth-based branded content. I showed you a couple examples of that earlier. And then I showed you just a still image of some content that we developed. The reason we were concerned about this is that branding is a powerful driver of behavior change, as I was talking about earlier. And it's also a kind of confound for us in this study, because the Truth Initiative has been around for a while. People are aware of it. There's pretty high brand awareness among this 18 to 24-year-old age group, which is either the target of Truth or maybe they're just slightly older than the target of teenagers. That has been one of the traditional groups that Truth has tried to reach. So it's like kind of confound for us. We're concerned that maybe this prior brand awareness sort of limits the extent to which we can see an effect of our new content in this randomized series of randomized trials that we've been conducting. And so we developed our own content to try to isolate these effects. This is an example that I'll show you here just now. And basically all of our participants got both the Truth branded content and unbranded content. And we're going to try to tease that out in our analyses.
I felt a lot of anxiety, and I was always overthinking things, even small things like texts from my friends. I didn't even know that was connected to vaping until I stopped, and I wasn't as bothered, and my mental health unlocked.
So that was actually a very popular post. It got a lot of post engagement, like shares, etc., comments, etc., that we had developed, and this is part of this overall component of our study where we're trying to sort of isolate the effects of branding versus unbranded content. Unbranded in the sense that, you know, this is content we created specifically for this study. It's not part of a larger campaign. Okay, so that's one example. We used this retargeting, remarketing technology. We've conducted randomized controlled trials at scale. We've demonstrated positive pro-social and health effects of that, at least preliminary outcomes. And this is another example. It's using the same technology. This is in a global health setting on a different topic. And this is more focused on building communities of interest and providing support. another one of our AI principles that I talked about earlier for social and behavioral change. And this is a study we did funded by the Gates Foundation, where we were promoting COVID-19 vaccine uptake in Nigeria. It was a nationwide study conducted in 2022. Again, it used this virtual lab technology. It was a campaign that used a social influencer strategy. So the actual delivery of the social media content was through the accounts of various social influencers. And it was designed to change norms, basically promote pro-vaccination norms. It was run in 6 Nigerian states. And then there were of the rest of Nigeria, 31 other non-treatment states did not receive this campaign. So we used that as a basis of our study design, a quasi-experimental kind of design that I'll talk about in just a second. We had a theory of change for this program. It was based on the idea of trying to overcome vaccine hesitancy. There's a construct called the 5 C's of vaccine hesitancy that has to do with like confidence in vaccines, complacency that maybe you're not at risk of the disease the vaccine is supposed to promote. And there are 5 C's that you can target to try to reduce vaccine hesitancy. So we were focused on that. We were trying to promote social norms about vaccination. I talked about norms earlier as a driver, that social media can promote normative beliefs because of the scale and reach. And that may change to promote more people getting vaccinated. Also, you know, our social influencers, are they a trusted source? They're the supply of the message, and we have to balance that against trying to promote demand. We were also concerned about things like people's ability to get vaccinated. You know, if we're reaching people that maybe are a long way from a hospital in rural parts of Nigeria, are they going to be able to get vaccinated? So we measured that, and it was part of our theory of change. This figure kind of illustrates what we were trying to do. It's an earlier publication in the journal Vaccines, where we looked at this. Basically, this idea that if you run a COVID-19 campaign, there are a number of things in the environment like structural, economic factors, availability of vaccine, et cetera, that mediate a process moving from left to right in this figure. And that process leads people through awareness that the vaccine's available, beliefs about it, social norms that they accept it, forming an intention to vaccinate, and then eventually vaccine or vaccination uptake. So a fairly simple model, but we were using this to design our study and our intervention. Another thing we thought about and really focused on was the idea that there's a kind of persuadable middle. And I think this is a principle that applies to a lot of interventions in public health. You know, there are people who are just going to do the behavior no matter what on the left-hand side. They have high demand. And in the case of COVID-19 vaccine, they're going to get vaccinated as soon as they can, like me, for example. You know, how many shots can you give me and how quickly? And maybe many other people who are here today. They're going to take the vaccine as soon as they can. And on the far right-hand side, there are people who, for various reasons, they might be religious or other cultural reasons, they're absolutely not going to take it. But in between, there are a large number of people who have some variable degree of hesitancy. Like they have concerns. They're maybe not sure that it's safe and effective, for example. They're not sure that other people like them are getting vaccinated, a variety of reasons. And so a study was done by some colleagues of mine about a year before we did our campaign, our intervention, and found that there was this definable, persuadable middle. And we were specifically interested in reaching those people. And we collected data through our study to try to make sure that we had sufficient sample of these people to be able to analyze this persuadable middle effect. So that was another part of our approach. This is what I mean by social influencers. We're not talking about Ronaldo, who it turns out is the largest social influencer in the world, if you weren't aware of that, the football star, or Taylor Swift or somebody like that. No, what we're talking about are like healthcare workers, or maybe a local celebrity in the middle, or maybe a pastor who has a big following, a big church in Lagos. You know, these are people who can be very influential. In fact, they may be more influential than some sort of distal, you know, celebrity. You can think about kind of micro to mid-level influencers who maybe have thousands or tens of thousands of followers, but to their community, they're really influential. And so this concept has been used in some projects in recent years. This idea of very small, like nano to micro influencers have certain characteristics. Like, if my friend, who I know very well, I've known for a long time, promotes something to me on social media, my conversion to that belief that he or she is promoting might be very high because they're very trustworthy for me. Whereas a celebrity at the top of this pyramid on the right hand side is extremely visible. They're as visible as they can be, but like, let's say they've never talked about a health topic before and they all of a sudden start talking about health. They may not convert people. People may not engage with that because it's not who they think that celebrity is or represents. So, social influencers can be really a very effective intervention strategy in the digital media world. But what kind of influencer? And there's the potential for them to change social norms. And in fact, this campaign was highly effective. So in our study, we collected data from across the country, a sample of over 10,000 Nigerians, and we evaluated the effects of this campaign. Again, this was done through the virtual lab, purely on social media. The intervention was delivered on social media through the influencer model. The surveys were collected on social media, and we had measures of vaccine hesitancy, social norms, vaccination behavior, as I mentioned earlier. We saw over time a 6 to 9% higher rate of vaccination in the treatment states that got the campaign compared to those that didn't. We control for a whole host of other variables, dosage in particular, or delivery of the campaign. And so, and we saw that this effect persisted. It was strongest about 3 months after the delivery of the campaign baseline. And then we had a follow-up about 3 months later in 2022. And then 6 months later, we had a second follow-up. We still saw this effect, although it was somewhat attenuated at the second follow-up, although more people were getting vaccinated by then. And then the question was, well, how did this happen? What happened to cause this? And what we found was that people who had more positive vaccine social norms at an earlier time point were more likely to get vaccinated at the follow-up time point. The social norms was the driver of vaccination. So it validated our theory, our hypothesis for the study. Okay, a third case study, 2 more quick ones, and then we'll stop and we can have discussion, answer questions. This is a slightly different kind of approach. This is personalized and tailored. And it's an app called Kalia that is focused on promoting breastfeeding. It's an app to promote breastfeeding with an emphasis on low-income African American women living in the Washington, D.C. area where I work. And this was funded through 2 what are called Small Business Innovation Research grants. These are NIH grants working with a large hospital system called MedStar. So the participants were basically recruited in a clinical setting where they're a pregnant woman coming in for care. She's utilizing an existing patient provider app called Baby Scripts. And we developed this Kalia app as kind of an add-on or like a feature within the Baby Scripts app, which all the pregnant and early parenting mothers-to-be and moms were using. So it was the existing patient provider platform, and then we developed this new app to go into that platform. And we conducted research on sort of how to optimize the app and how to make it effective. We're currently running a randomized trial to evaluate the effects of this app. But it's interesting, some of the features that we used. These are just some screenshots from the app. Some of it's informational, some of it's motivational. It's highly personalized. It gets to know you. So Catherine is the mom here. It has recorded content like videos, some of which are just trying to inform you about things that are going on with your body, for example, the importance of how babies build up immunity from their moms. And then also other content that's more, I would say, entertainment education. We had a whole series of videos that were kind of motivational from moms kind of explaining, talking about their experiences and what worked and what didn't. And Also, you can record your activity. So there's a self-monitoring component to it. And you can see in the middle screen there, the upper part of the middle screenshot there, various things that you can record and keep track of and see or watch your progress over time. And then the app basically is designed to sort of learn from your behavior. And we use the kind of the guide through the app is an avatar. And these AI avatars guide the participants, and they sort of evolve to fit the situation as the participant moves through the breastfeeding process. So maybe early in the process on the right-hand side, you know, mom's up late at night, she's tired, you know, she's with her baby all the time. And, you know, over time, she's using the app, and the app is learning from her use and personalizing more and more what it's offering, making suggestions based on the use patterns, maybe trying to redirect if certain content isn't being used as much as we would hope it would be. And it promotes things like goal setting, engagement, app use. Then maybe later on, mom's getting ready to go back to work. You know, the avatar has kind of evolved to fit the situation and the look and feel of where she is in her process. So we're using AI in these ways. The fourth and final example that I'll give you is a good example of, I guess, what I would call trend spotting and rapid response from that earlier analysis that we did on kind of benefits of AI. And this is a new project that we haven't gotten fully up and running yet, but we're hoping to in the near future. It's called AIM, Artificial Intelligence Media Monitoring. And there was a study a couple of years ago that identified 9 strategies that are employed consistently by digital media literacy interventions. So things like trying to debunk and rebut false information, like misinformation, disinformation, trying to create source credibility, the idea that this particular source is credible for me. Media literacy to kind of identify not credible sources that are providing mis or disinformation, inoculating against mis and disinformation. So this study by Kozareva and colleagues analyzed this, and we used some of this information to design this AIM tool, which I will describe to you here very briefly. That study found that certain populations were more or less affected by these various strategies, and so they aren't necessarily all effective for everybody. So here is an example of what we've developed for AIM. It's basically a tool that will track online activity and identify potential misinformation in a person's feed, and it will counter misinformation through myth busting. It's an opportunity in particular for collaboration between AI and social media companies and academics. There is an initiative that's being sponsored by some UN agencies, United Nations agencies, to develop a prevention consortium, substance use prevention consortium in particular, with AI companies. And I've just been at a meeting in Vienna a couple of weeks ago that was focused on that. Let me just show you an example of some of the content that we've identified. These are like examples of content that we would try to counter message.
Relate. Do you know what these are? And you probably have a boyfriend who's addicted but doesn't want to.
Yeah, dude, yeah, I'm addicted. Like, the other thing that they don't tell you is you lose so much weight just placing Zen with any hunger. Was down like 30 pounds a month. Ozempic.
Yes.
Works.
So Zen is one of these oral nicotine products. He's got the little pouch in his mouth. He's absorbing a huge hit of nicotine. And you know what our AIM tool is designed to do is to counter message that. So basically, a large language model would be, you know, tied to the person's feed, and they get exposed to content like what I just showed you. It would develop and deliver to the top of the person's feed counter messaging. So nicotine, one message might be in a post, like in a post that would have the same kind of attention value potentially as what you just saw. You know, nicotine can harm the developing brain, intensify depression, anxiety, harm cardiovascular health, debunk this myth that Zen can induce weight loss. and point out the harmful effects of Zyn and other nicotine products and how they outweigh any potential for their use in weight loss. So basically, the AI would help to debunk automatically in response to content that a person was exposed to on social media. Again, that's a product that we're still developing, where we have a grant pending that we're hoping will be funded soon, and we can start testing this product. So just to conclude, different future research challenges and opportunities. I think it's important to recognize that digital isn't everything. It's very powerful. It has all these positive features. I talked about several of these benefits of AI and digital media for behavior change, but combining those with traditional channels, community-based channels, I think is going to be key to optimize public health programs. Or, for example, combining like virtual interventions with clinic or healthcare-based interventions, where you've got a provider interacting with participants. It's not just through a digital channel. I think those are going to be important to develop and optimize further. Just the features of social media as an intervention channel. Are we going to encourage antisocial online behavior? Will people consume and respond to digital media for behavior change in an impactful way? I've shown you today that there's early evidence, preliminary evidence that that's true, but we need to do a lot more research to show that that can be impactful and can be maintained impactfully over an extended period of time. Technology is going to continue to change rapidly. We need to keep up with that. And what are the implications of that for the kind of research that we're doing, and also the pace at which we're doing research? A lot of research funders are not really designed to respond to very rapidly changing technologies and changes in social activity. So we're going to need to speed that process up. And then how do these research findings translate into community impact to benefit the communities that we serve? So I think those are some key challenges that we'll face going forward. So really happy to have had a chance to speak with you about my research today. I'll stop there, and happy to answer questions. I'm going to stop sharing, and
yes.
I can come back to that if needed.
Excellent timing.
I stopped
Thank
sharing.
you.
Hang on, let me just get back here. Sorry, I'm not seeing. Okay, there we go. Yeah, sorry.
So there've been a couple of questions already.
Yeah. Okay, great.
So this was a comment and followed by a question from Dr. Rochelle. This model, I think it was referring to the remarketing, I think, or retargeting, heavily relies on digital literacy and social media use of the target participants. How do you counteract that during your study design? Can you disseminate some of these interventions via healthcare providers? I think you showed an example.
I think that maybe my concluding comment sort of spoke to that, the idea that potentially they could be. I guess there's a lot of things here. It's an onion with a lot of layers to it. I mean, one thing is, I was talking in sort of overall theme of this talk is that there's tremendous power and potential to the use of digital platforms to conduct research. We recruited a sample of 8,400 young adults, a study that would have cost an incredible amount of money to conduct if you were doing it in person. And yet we were able to do it at low cost relatively rapidly. So there's an incredible scale and reach power to this kind of research, but it's not necessarily the be-all, end-all solution, which is what I was really trying to get at the end, is that I think what we need to do is figure out how to combine these methods with other methods that, other analog methods, if you will, and try to optimize the value. But yeah, I mean, just the other point being, the question being about like combining these with like clinical interventions and so forth. The Kalia example, where we're recruiting patients in a hospital setting and then giving them a digital intervention that's embedded within clinical care that they're already getting from their provider. There's obviously a lot more you can do with that, right? And so I think, hopefully that's at least a partial answer to your question. I'm aware that there are both strengths and limitations to these digital platforms, but the strengths are tremendous. And, I think we need to take advantage of them, given that everybody has one of these mobile devices. They're using them all the time. That's where people are spending an awful lot of their time. So let's see if we can intervene and be successful, in that setting.
Yes, thank you. think that the underlying assumption is that there is a minimum level of digital health literacy, that these segments of the population have, which determines the fact that you have a workable intervention if you want. Of course, then if you had to target people that do not have access to the internet, do not have access to the resources, then you will choose a different approach.
Yes, you would. Yeah. But I will say, I mean, even in developing low and middle income countries, I mean, the level of, for example, mobile smartphone penetration is incredibly high.
Mm-hmm.
I mean, Nigeria, you might think of Nigeria as sort of a low to middle income country. Everybody's got a mobile device. I mean, not literally everybody, but a very high percentage of the population. Kenya, another example, very high mobile phone penetration. So it's I think it's something to think about.
There's a quick question from Matthew. Is the Kulia app on open access?
It is not. It's still in a testing phase at this point. The idea would be that it would become we would disseminate it through our partner at MedStar, and it would become part of their clinical care system. It would become a standard part of this Baby Scripts app. But right now it's basically just a test app.
Okay, thank you. Now we have a question from a colleague of mine. I recognize her name from the UAE, if I'm not mistaken, Fatima. Question 1, will AI-generated content be perceived as a trustworthy source among the target audience in a social media environment, since it has been associated with misinformation for a very long time? There's a follow-up question. Will AI-generated content be verified by the intervention team before being posted?
That is a fantastic question. I will say, I don't generally say great question lightly, but that's a good one, because it's interesting. So in our formative preliminary research for the Kalia app, we were concerned that an obviously AI, if you look at those avatars that I showed you, it's pretty obvious they're AI generated. I mean, anybody who's savvy would recognize that. And we were concerned that people wouldn't trust them. They wouldn't be source credible. In fact, we found the opposite, that people actually thought the AI generated avatar was better, at least for that purpose. That situation, that population that we were working with, they actually preferred the AI generated avatar. I don't have a really detailed explanation of why. But that was the result of our formative research. This was focus groups we did with members of the target population. So they actually prefer the AI. Obviously, we have counterexamples to that, like the fact that people are concerned about AI being used for like deep fakes, for example. We have even politicians using AI to generate obviously false information, try to persuade people to beliefs that are manifestly false and maybe even harmful to them. So, I think it really depends on the context and also who's behind the AI. Like, is it just the only source that's visible is what you see on the screen? Or is it known to be coming from the NHS in the UK, or known to be coming from the University of Birmingham or some other trusted source, right? So it's not necessarily just the AI generated content that quote unquote is the source or the messenger, right? It might be brought to you by somebody, and that brought to you by might be extremely important, either in a positive or negative way, frankly.
If I may jump in on this, I think what you showed us also was an image of a situation. So it was describing a person in that situation, showing probably some sort of general conceptual ideas about, which might be different if you had to be more specific about a task or an object or a person that is doing something.
You mean the avatars that I showed from the Korean? Yeah, but you're right.
Acceptable.
Just remember that those avatars that was just like a screenshot. That person, that AI generated person, would be like your friend on the app. That's like your trusted advisor. You log in on a given day, she comes up and you're interacting with her. She's saying, hey, why don't you go watch this video now? Why don't you record your, breastfeeding activity from yesterday, etc. So it really would become like a trusted friend or advisor. And so then the question becomes, is that the right approach? Let's say you took that and put that in a different situation. Maybe now the activity is weight loss or something, right? Maybe the AI would or wouldn't be trusted, in that different context. So just to make that point.
Probably knowing that is an AI generated persona would make things different if it was a human. But anyway, there's another question from Fatima. Just
Sure. Yeah.
How cooperative are healthcare providers in embracing digital media interventions for behavioral change?
How cooperative?
Cooperative, yes. How cooperative?
Boy, I would say a very, very wide range. I mean, I have collaborators who are, really into use of digital technology, like my partners at MedStar, where we did the CALIA project, they're doing the CALIA project, and have done other digital grants focused on things like healthy weight management, actually. There are people who really are into it and see the benefits. I think there are others who are, maybe those are the early adopters. Maybe we have some laggards also. And, I think it depends a little bit on the clinical setting that you're in. Some, like in the US, some of the larger, better funded healthcare systems, we have these private hospital companies that have really adopted technology. They, are definitely earlier adopters, whereas you have others who are not. So it's a wide range, I would say.
Okay, we have I would say one last question from Syed. Syed, you mentioned that you received answers from the youth confirming that a certain percentage of them didn't want to vape again after viewing the ads or something of the sort of, if I remember correctly. How are you so sure that they can be verifiable or useful measurement, because that can also be lip service from a struggling youth who doesn't particularly have any intention of quitting?
Well, we have validated, there's been decades of research on survey data, on survey-based data on people's response to questions about especially self-reported nicotine and tobacco use and antecedents of use. And so, we know what the potential error in those data are, and it's, there's a science to that that's very well established. So we're not just sort of making up questions and asking. These are, validated scales that have been used for a long time. So that's the basis of that.
I have a question, if nobody else has one, about the remarketing. I like this approach, and I was wondering, how do the database define the behaviors like vaping or the personas of a vapor, of a smoker?
Yeah.
And how accurate is this profiling?
Yeah. So, in a person's, there's an algorithm that we're using that is identifying data in a person's profile and their online activity that suggests that they may have a characteristic. And that character, there could be a lot of characteristics, right? But the one we were especially interested in was use of e-cigarette products. So think of that as like the funnel, right? People that fit certain criteria get into the funnel, and then they would receive the recruitment content. They click on it, they start interacting with an AI chatbot, which essentially screens them into the study. It asks them a series of questions to validate that we think that you're eligible for our study. Now we're going to validate that you are eligible. And when I showed you that little graphic that showed our study design and the recruitment process and the randomization, the thing to note about that is that the initial data that we used was really accurate. We didn't lose very many people during the screening process who later, in screening told us something that excluded them from the study, like that they weren't a vapor, let's say, right? We were trying to get a certain number of people who qualified as vapors and non-vapors, right? And once we had all the vapors we needed, we wouldn't be looking for anyone, if that makes sense, right? We had quotas, essentially. But the screening process worked really well because there's just a lot of data out there about people's online behavior. And so it really validated the approach.
Okay, excellent. Thank you, Doug. Thank you, Professor Doug Evans, for this interesting seminar. I think it was very well attended, let's say, compared to the other webinars we had. Anyway, if you're interested in joining the webinars, I posted the links in the chat that will be available on the website and on this recording as well when we post it on YouTube. Thank you very much all for attending. I wish you all have a nice day, evening, morning, and Ramadan Kareem.
Thank you for having me. All right, bye now.
Thank you.